then insert the guide wire, which should go in nice and freely. I'm going to withdraw the needle over the top of the guide wire. And I'm going to make a small incision in the skin at the point of the guide wire enters the skin. And then I'm going to pass the dilator over the top of the guide wire. And I'm aiming just to go through the skin and down to the level of the pleura. I don't need to go in any further than that. Just to allow the drain to pass easily through the cutaneous tissues. I'm then going to pass the drain over the wire, making note of which way it angles. So I'm going to angle it down for an effusion or a hemothorax, and up for a pneumothorax. So the guide wire goes through the drain, and make sure I hold on to the end of it, and then pass it gently through the skin. And likewise, it should pass nice and easily into the pleural space. I can then withdraw the internal sleeve and the guide wire at the same time. It should come out nice and easily. I can then connect my three-way tap to the drain, three-way tap to the connector, and then the connector can be attached to my underwater seal, and I have a third port to aspirate from if I need a sample of pleural fluid. I'm then going to secure the drain to the skin, either using a suture or a dressing or both. So the chest drain is connected to an underwater seal system, which comprises of a bottle and a connecting tube. The bottle needs to be filled to the mark with sterile water. So the connecting tube goes into the bottle and then screws on. And then there are two tubes, one to connect to your drain, the bung comes off, and then an open port to air, or that could be attached to suction.
Once you have finished placing the chest drain, it is important to go back and reassess your patient, in particular checking that their airway, breathing and circulation is stable. Only once you have done this should you proceed to ordering a chest x-ray to confirm the position of the chest drain itself. Remember, as with all procedures, it is essential that you document your procedure thoroughly in the patient's notes. This should include the size and sites of the chest drain placed, any complications that may have occurred during the placement of the drain, and a description of the colour, consistency and quantity of the fluid that may be draining from the chest cavity. If you place the drain for a pneumothorax, it is important to document that the drain is swinging and fogging on expiration.